Percutaneous pulmonary valve replacement, I shall be talking about that. So many congenital heart diseases require right ventricular outflow tract reconstruction. So almost 20% of newborns with congenital heart disease have complex anomalies which require surgical reconstruction using a patch, a bioprosthetic valve, or a valve conduit. Now, those lesions may include tetralogy of Fallot, pulmonary atresia with and without ventricular septal defects, truncus transpositions, some forms of DORFs, congenital aortic valvular anomalies previously treated with Ross procedures. So degeneration of bioprosthesis and valve conduits result in progressive RVOT dysfunction with possible PS or PR. Severe PR will be present in almost 80% of patients 10 years down the line following a primary repair. Now, transcatheter pulmonary valve replacement is a non-surgical option to restore the pulmonary valve function in children and adults with congenital heart disease. The procedure was first performed by Bonhoeffer in the year 2000. And the comparison of the American College of Cardiology and the American Heart Association and European Society of Cardiology have labeled it that a patient who is symptomatic with moderate to severe PR is the class 1 indication for a valvular replacement. Or a patient who is asymptomatic with moderately severe PR with RV dilation, or an asymptomatic patient with moderate to severe PR with ventricular arrhythmia. So these are the indications for valvular replacement. This is basically, is it on? This is basically the algorithm to follow when to and when not to replace a pulmonary valve. Now, as you can see, this is data that I've gathered from AFIC over the last 5 years. And as you can see that slowly and gradually, the number of valvular balloonings that we have done in our lab have steadily increased. And with the valvular balloonings of the pulmonary valves in patients with tetralogy Fallot, unrepaired tetralogy Fallot. In the previous era, it was not considered something that was a surgical option. So we were, in order to palliate patients, instead of going for BT shunt, you would palliate them with pulmonary balloonings or RVOT balloonings or with stenting procedures. Stenting. So transcatheter pulmonary valve replacement is one of the most exciting recent developments in the treatment of congenital heart disease. And it has evolved to become an attractive alternative to surgery in patients with RVOT dysfunction. We have been involved in 4 cases where we implanted transcatheter pulmonary valves. These were venous P valves, larger venous P valves for native RVOTs. And we were helped by Professor Sir Shakil Qureshi from Guy's and St. Thomas NHS Foundation Trust, who helped us and is still continuing to help us in implanting these valves. So we are actually in an evolving stage. So now to establish the indications for a percutaneous valvular implant, we have to go through the normal routine of having a surface ECG and an echocardiographic evaluation, which includes the amount of PR, a qualitative PR, PS, right ventricular and RVOT measurements, ventricular sizes and functions, and any other associated findings on echo. Though we do not carry out these exercise testings, but there is a protocol that an exercise testing should be done, which includes gas exchange, oxygen uptake, carbon dioxide output, tidal volumes, minute ventilations, ventilator anaerobic thresholds, and respiratory quotients. Cardiac magnetic MRI, this is actually the cornerstone for a pulmonary valve implant, where we need to know the sizes, dimensions, volumes, regurgitant fractions, ejection fractions. So this we can achieve with cardiac MRI. We have also performed CT angiograms, CT grams on patients and complex anatomies to evaluate the relationship between the pulmonary trunk and the aortic root, to assess the coronary artery anatomy and RVOT size. Also, it is possible to estimate the risk of coronary artery compression according to distance between the coronary artery and the landing zone. We do not have the facility for 3D printing, but we had this opportunity to have a liaison with our friends in England, where they allowed us to go for a 3D imaging, and in which we could really reconstruct the RVOT and find out whether it was feasible to put in a valve or not. The patients who were considered ineligible for a percutaneous valvular implant were those who had RVOT morphology based on visual assessment of 3D reconstruction, where we found that this was not suitable for valvular implant. Those patients who were likely to develop coronary compression, or those whose conduit function was better than the anticipated on hemodynamic study. Those patients who had branch pulmonary artery stenosis, or who had conduit stenosis, and that could be relieved otherwise. So as you can see, we can have different types of RVOT morphologies, and the ones which is not suitable for a valvular implant are like the conus type, the one which looks like a pyramid. So various shapes and forms. This is a venous P valve. And as you can see, that this valve was the one that we implanted. It's a large valve, and that's its delivery system. The French sizes that are being used are 19 French, 22, 24 French. Age of the patient varies from 12 years to 70 years. Now, the patient has to be symptomatic and has to meet the MRI criteria for intervention. That is, has to have an ejection fraction close to 45%. Regurgitant fraction should be more than 30%. And the end diastolic volume, if it's increasing more than 150 mils per meter square. So we do have complications, and the complications, as we do more, we will need to know what other complications can occur in these valvular implants. There are other types of valves, percutaneous valves available in the market. These include the Melody valves, available in 2 sizes, and with their delivery system. We have the Edwards Sapien valves. This has the potential for use in native outflow tracts up to 29 millimeters. The Edwards Sapien valve has a transcatheter pulmonary valve Altera adaptive pre-stent. So you can actually pre-stent the native RVOT and put in a Edwards Sapien 3 valve. And this is the transcatheter. This is the Harmony valve from the Melody. Melody valve, they have also a valve which is for the native right ventricular outflow tracts. And this is the Harmony valve. Available in 2 different sizes. Then we have a self-expanding porcine pericardial venous P valve. Is available in straight and flared designs by Venus MedTech Hongshu from China. So I'm going to present this patient who was 18 years old. He had a primary corrective surgery performed at 1 year of age. His basic cardiac anatomy was tetralogy of Fellows. So he had his surgery done when he was just 1 year old. So he presented to us. We did an MRI, and we found that he was an eligible patient for a percutaneous pulmonary valve implant. So right and left groins were used for cardiac cath study. Arterial and venous lines were taken on the left groin using a 6 French femoral sheath. Venous lines were taken on the right groin using a 6 French femoral. So on the right side, we took 6 French femoral, and on the left, we took both arterial and venous lines. Venous check angiograms carried out to assess the size and morphology of the pulmonary veins before the procedure. We made sure that the ACT levels were more than 250 milliseconds. Using a 6 French pigtail, RV angiogram in RAO 30, cranial 15 at 20 mils at a rate of 20 mils per second at 600 psi was taken. Frame rate was 15 frames. Then pressure of the RV and morphology of the RV was noted. Similarly, An injection in the same plane was given with the 6 French pigtail placed in the main pulmonary artery. Another injection was again done in the LA position 90 with the pigtail at the same place in the main pulmonary artery. The morphology of the pulmonary artery, degree of pulmonary regurgitation, and the pressures were noted. Pressure gradient across the RVOT was measured. Now we used a Linderquist guide wire 035 with total length of 260 centimeters, was then parked deep in the left pulmonary artery using a 6 French catheter from the right groin. Now using the left groin, a pigtail was passed in the femoral artery and placed in the left ventricle to assess the left ventricular end diastolic pressures. The arterial pigtail catheter was then withdrawn and placed in the aortic root for later coronary angiograms. Using the same left groin, another 6 French pigtail was passed in the femoral vein and placed in the right ventricle. So now you can see we have all the 3 vessels engaged. We used a 34 millimeter sizing balloon with a 75 centimeters shaft length, and it was passed up the Linderquist wire and placed across the pulmonary valve deep in the main pulmonary artery. The idea of balloon sizing the pulmonary valve was to know the exact size and dimensions of the pulmonary valve, and also to see whether this size would not cause any kind of coronary compression. We used syringes 50 ml with a 2-way tap at the balloon end, and enough contrast was injected into the balloon so that it completely occluded the RVOT and was fixed in the main pulmonary artery without any bobbing to and fro. Enough contrast was injected into the balloon so that it completely occluded the RVOT, as you can see that. The procedure was then repeated with the camera in areocranial position and check angiograms in the aortic root, and the RV cavity were repeated. As you can see this, we are repeating. So we are actually seeing that the annulus size is enough to completely occlude the flow going into the pulmonary artery. And at the same time, we are doing a coronary angiogram in order to see that there is no coronary compression when we dilate the. So this is the venous P valve system that we used for our patient. It has a valve diameter ranging from 16 to 36 millimeters. The flare is 10 millimeters more than the valve. And now it's available in just 2 lengths, that is 25 and 30. They're probably going to stop production of 35 size. There are delivery systems available, 22 and 24 French. And so what do? We assess the most distended diameters. We measure the waist, the most dilated, and the length. So these are how the measurements are made, that you take all the dimensions, take the waist, measure the length, and then come up to a conclusion. So we decide the landing zone. That's the landing zone. And then these are the measurements that we do before we think which valve. So decide the landing zone. This is the flare end. And then we see that the length of the valve that may be required was something like 20 millimeters. And from the available sizes, we get to the diameter and come up to a conclusion that we will use a size 26 by 25. We selected, for our patient, we selected a venous P valve with length of 25, with that diameter of 34, and with a Mullen sheath delivery system, 24. We pre-dilated the right groin, used a 24 French venous P valve sheath, and repeated angiograms taken in LAO. So we see that we have this Mullen sheath up in the main pulmonary artery. As you can see, by repeated angiograms taken in LAO 90 and RAO 30 cranial, the position of the sheath was adjusted along the anterior border of the trachea, so not to go distal to the right pulmonary artery. So first is positioning of the sheath. We are intending not to go just position the sheath first. 6 French pigtail placed in the RV was then advanced into the main pulmonary artery for later injections and pressure measurements. The valve was then slowly advanced and steadily unsheathed so that the 24 French melon was at the lower end of the valve. Repeat check angiograms were then taken during the positioning of the valve in LAO 90 and RAO position. The carrot of the valve was advanced distal to the tracheal mark in the LAO 90. And slowly we have removed the sheath. We made sure that it is completely uncovering the valve. The flare end of the valves was adjusted in the main pulmonary artery, proximal LPA, and repeated check angiograms were taken to make sure that no branch PAs are obstructed. The valve was gradually deployed by clockwise rotation of the deployment sheath in such a way that the proximal markers coincided with the proximal waist. And the remaining constrained valve was then progressively exposed under guidance by repeated check angiograms. As you can see, that slowly and gradually we're trying to, since it's nitinol, it opens up as it gets to the temperature of 37, the body temperature. So initially it may appear that it is a small sized valve, but eventually it takes the size of the pulmonary artery.
So how
that's about the schooling pair.
So now we can see that we have a fully deployed valve, almost fully deployed valve. And this is the point where we are actually rotating and uncovering it, uncovering the capsule from the valve itself. At the same time, we are also giving check angiograms in the right ventricle to ensure. And now you can see in the right frame that it's a completely deployed venous P valve at the right position. Also made sure that it is completely disengaged from its covering sheath. And then a check angiogram was taken in different views. The carrot is slowly withdrawn by pushing the wire forwards, making sure it does not get itself tangled within the device. So the carrot is actually has to be taken out very carefully. And the direction and position of the carrot has to be manipulated with the carrot itself and with the Linderquist wire. So now we have a fully deployed pulmonary valve. As you can see, there is no pulmonary regurgitation and there is no obstruction. We look for perfusion to both the lungs. We see that there is no paravalvular leak. And the apposition of the valve to RVOT main pulmonary artery should be perfect. And then we take down the pressures. This is a post-procedural echo done. As you see that there is no PR. We remove the sheath when the ACT has come down. Either we use a figure of 8 suture or we use a per closer or proglide. Heparin is given for 48 hours. Ultrasound abdomen for retroperitoneal bleeds. And the patient is placed on dual antiplatelet for the next day and continued indefinitely. We have a fluoroscopic examination of such patients after 3 months, and we will do an MRI after 6 months. This is the patient that we put in a pulmonary valve. Thank you.